Good morning, everybody. My name is Peter Nilsson from the Lund University in Sweden. I've been invited to talk about the PolyPill strategy in cardiovascular prevention. Is it relevant for patients with diabetes? I will review with you recent studies based on the PolyPill strategy and also talk about possible implications for treatment of type 2 diabetes. As you know, the idea of the PolyPill is really to combine different pharmaceutical agents into one tablet or one capsule to make it easy for the patient to remember taking it, increasing compliance, but also achieving synergy between the different components. Over the years, there has been a debate what to include in a PolyPill. There should be a statin, blood pressure lowering agents, maybe even aspirin or folate, according to some suggestions. So the final optimal format of the PolyPill is not yet established. And if we add diabetes, maybe also anti-diabetes agent should be included, for example, metformin, but I will come back on that. Of course, there are some pros and cons to be acknowledged in this debate about the PolyPill. On the pro side, we have simplification of therapy, additive effect. It's evidence-based now. I show you the evidence. It's cost-effective and can be combined with lifestyle improvement. And many people think, including Salim Yusuf, a world-leading cardiologist, that this is a realistic strategy for global CVD prevention. However, on the con side, we have some other arguments. Is the PolyPill for all or for selected few? How to up-titrate dosages because you have a fixed dosage within one tablet, and maybe there must be different tablets with different dosages, not solved yet. It's difficult to evaluate adverse effects because several agents are combined in one pill, so it's hard to know which one will cause adverse effects. Does it mean medicalization of large population groups if it's rolled out in the elderly population, irrespective of risk, as has been proposed? Should it be prescribed by physicians or even free as over-the-counter purchase in pharmacies? This has also been debated. And what is, in the end, the role of physicians if people can take decisions themselves to take a PolyPill or not? The idea about the PolyPill was introduced by Professor Nicholas Wald in London, UK, way back in 2003, a publication in British Medical Journal with the argument that a PolyPill could reduce heart attacks with 80% if it was to be taken by a large proportion of the elderly population, irrespective of risk factor screening. More recently, we have seen two very important randomized controlled trials strengthening the evidence for the PolyPill. The first one was carried out in Iran, northern Iran, close to the Caspian Sea, and published in The Lancet 2019, when a PolyPill was used combining aspirin, enalapril, or valsartan, hydrochlorothiazide, and atorvastatin to treat individuals at increased risk. So there were two study groups, a PolyPill group, a randomized PolyPill group, and a minimal care group. However, for various reasons, there was not a placebo group. So the comparative group was a minimal care, as listed here. And the outcome, you can see that after a follow-up, 5 years of follow-up in more than 6,000 patients, major cardiovascular events were significantly reduced in the PolyPill group, and this was so both in men and women. So this is a strong argument that the PolyPill worked to prevent major cardiovascular event in this, I would say, developing country. It's not a rich country, it's not extremely poor, but it's like in the middle. So it was successful. More recently, Professor Salim Yusuf launched this study that used the factorial design in many countries in the developing world. They used a polycap active versus a polycap placebo, and the constitutions were aspirin, active or placebo, vitamin D, or the active components of the polycap, including statins and antihypertensive treatment. So in a more recent publication, the outcomes were described, however, not addressing vitamin D supplementation. We still have to wait for these data. So this was the design of the so-called TIPS-free study with this factorial design. And as you can see here, many countries were involved. Leading countries were India and the Philippines, with the majority of patients. About half were women, mean age 64 years, and self-reported diabetes was in fact a third. So it's relevant, this study is relevant for patients with diabetes, at least in these countries. The idea was to give a polycap versus placebo and add on aspirin versus placebo, as I mentioned to you. Late 2020, the TIPS-free study was published, and the bottom line was that the PolyPill strategy proved to be efficient to lower the incidence of cardiovascular events compared to placebo. And I show you the data. Please remember that these patients were recruited to be at intermediate cardiovascular risk. So they were not low risk, they were not high risk, they were at intermediate cardiovascular risk based on a score system. First, I show you the graphs for PolyPill, the polycaps versus placebo alone. And here you can see that it was a borderline significant result for the primary outcome, but when first and recurrent events were combined for the primary outcome, the effect was significant. When aspirin was compared alone versus placebo, there was no significant preventive effect as seen here. But when the PolyPill or polycaps was combined with aspirin versus placebo, there was a very significant effect in favor of the polycap, PolyPill plus aspirin. You may argue that aspirin is not appropriate for Western countries because there might be gastric bleedings, etc. But at least in this study, it was part of the factorial design, and it proved to be beneficial in combination with the polycap. And I remind you that the polycap included a statin and antihypertensive treatment, an ACE inhibitor, but if that was not tolerated, an ARB was substituted. So the bottom line was that polycap plus aspirin was more beneficial than placebo. Let's talk about diabetes, because type 2 diabetes is very prevalent, and these patients are really in need of preventive drug prescription. Most often we prescribe antihypertensive drugs, we prescribe lipid-lowering drugs to be combined with antidiabetes drugs based on guidelines. In this study, the authors tried to address the gap between an indication of a so-called cardiovascular PolyPill and real-life patients receiving a cardiovascular PolyPill, a theoretical cardiovascular PolyPill with statins and antihypertensive drug treatment. The same was true for indication of a diabetic PolyPill with several antidiabetes drugs in relation to the real-world situation, patients receiving the diabetic PolyPill. So you see the gap between indication and the real-world situation, people receiving these treatments. So to your left in A, you see patients with type 2 diabetes without vascular disease. And B, to your right, in patients with type 2 diabetes with established vascular disease. And you see that the gap still remains. So there is an argument in favor of thinking about a PolyPill also for patients with type 2 diabetes to simplify the treatment. It can also be shown that it's possible to combine several anti-diabetes drugs into one combination tablet, as done in this study based on 3 examples: empagliflozin, linagliptin, and metformin. That is an SGLT2 inhibitor, a DPP4 inhibitor, and metformin. So a combination tablet can be used for diabetes treatment, but if you think about it, there is a possible PolyPill combination for patients with type 2 diabetes. And in my own thinking, this is my idea, it could be based on metformin, of course, an SGLT2 inhibitor, a statin, a RAS blocker, either an ACE inhibitor or an ARB, plus a calcium antagonist or hydrochlorothiazide. I'm more doubtful about aspirin. However, in theory, this could be attractive, but in the end, it has to be tested in a randomized controlled trial. But I think in the future, we will see such trials. So coming to the end of my talk, I think that the PolyPill strategy in cardiovascular prevention is really interesting, and it's supported by good evidence now from large-scale randomized controlled trials. TIPS 3 also included 1/3 of patients with type 2 diabetes. The components of a PolyPill has varied over time, but the core is still antihypertensive drugs plus a statin, in some studies combined with aspirin. PolyPill has been suggested as an important tool for reducing the global cardiovascular burden, especially for developing countries and underprivileged groups. So I wonder whether this strategy could also be applied in secondary prevention, for example, post-myocardial infarction or post-stroke, but also for patients with type 2 diabetes. This is very attractive in theory, but we need new evidence from randomized controlled trials to support that strategy. But as you know, the number of patients with type 2 diabetes is increasing worldwide, and citing Salim Youssef, this might be the only strategy to counter cardiovascular disease on a global scale. So I leave it to you to think about, and I'm happy to discuss and take questions. Thank you very much.